Thank you very much, David, and thank you again, all of you, for making the time to come here. And I just wanted to take a pause to acknowledge that we're gathered here on the unceded traditional territories of the Coast Salish peoples, which include the territories of Musqueam, Squamish, Stolo, and Tsleil-Waututh nations. And I think it's important that we always remember that. So let me start with the update of BC Kidney Days. The BC transplant community has done an amazing job, and I think it's clear that there's a huge partnership between the kidney world and the transplant world. And so on behalf of all of you, I'm actually going to share with you what we've been doing in the last year. I'm going to remind us what kidney disease and who it affects in the province of British Columbia. For those of you that don't remember or can't recite by heart BC's model, I will remind you of that because it's quite unique nationally in terms of structure and function. And then we'll end with congratulations, new faces. And unfortunately, in taking a deep breath, realize that we've been doing this for 20 years. In 1997, for those of you that are old enough to remember, that's before Y2K and before we had cell phones as a way of communication in a real way. It's quite impressive. So in British Columbia, 1 in 10 people have kidney disease. There are over 14,000 people registered under the care of nephrologists and nephrology programs, and over 3,000 people on dialysis. And I think importantly, with the theme of all these 0 years, but 50 years ago, it was pretty possible that you didn't survive if you actually had kidney disease. So think about how far we've come in that. We have 6 health authorities, 5 geographical, and 1 called Children's, actually PHSA, 11 home dialysis training sites, 12 peritoneal dialysis clinics and training sites, and 13 hospital-based dialysis units, 14 kidney care or CKD clinics, and 27 community dialysis units. Again, we have a very large province with 4.3 million people in it, and this is our attempt at a hub and spoke model to make sure that we can deliver very much patient-centered care. You've seen this slide before. For those of you that can't see what's in the middle in the blue, that is patients and the community. And I think it's really important for us to remember that people exist independent of their disease. They live in their communities. We have tried to celebrate people at the center of the organizational chart, and then the health authorities are responsible for program delivery, and we as the renal agency provide the overarching support for programs, and we're accountable to the Ministry of Health and Provincial Health Services Authority for not just the outcomes but also for the finances. So here's a little poll for you. For 20 years, Promise has tracked patients on their journey through renal and even more than renal transplant care. And if you were to wonder how many patient journeys are recorded in Promise, you get a choice: 40,000, 80,000, 120, or 160. And the right answer is 120,000 patient journeys. Well done. Back to the slides. So what is important for us to realize is in 2007, we had registered around 7,000 patients with impaired kidney function not on dialysis, and at this point we have 14,000. I will remind you that in this province, not everybody with impaired kidney function is necessarily registered with a nephrologist or health authority program. In fact, the estimates of all people with kidney disease in this province are much higher than that, probably much more in the order of about 200,000. But this is 15,000 under the care of nephrologists and nephrology programs. We've improved access to care. I think Angus Ray is in the audience, and he'll remember the days that we used to go to the Ministry of Health and scream to get more dialysis chairs in various units, and we've not had to do that for a very, very long time, that we've been able to plan ahead and make sure that we actually have the resources that are required to take care of people when they do end up on dialysis. The provincial committee structure is described here, and for our visitors from both across the country as well as internationally, we have a number of multidisciplinary committees that have health authority and various discipline representation on each of the committees. But they have very clear work plans, deliverables, and actually span the gamut of research, education, and quality improvement initiatives, but all focused on the patient with various content areas, which I'll get through in a moment. And we've tried very hard to maintain this inclusive, bottom-up way of doing business. And I think when people from other provinces come and say, how do you get everyone to do this? It's like, well, everyone knows what the problem is. It's about taking better care of the patient. So you don't have to convince anyone to do that. So we have a new symptom management tool for patients and care providers on the website. Does anybody know which of the tools are on the website? Pruritus and restless leg, constipation and muscle cramps, nausea and fatigue, or all of the above? You're right. Means you're on the website. Good on you. Back to the slides. So let me just go through some of these multi-committee collaborations and give you some highlights of what we've been doing. So we do have this systematic symptom assessment called My Symptom Checklist, which is a modified Edmonton System Assessment score. That's actually quite impressive. We've rolled that out in almost all jurisdictions where patients can actually systematically document their symptomatology, which is a tool of communication between patient and provider. We have protocols and symptom guides, and we actually have a companion patient teaching handout as to what to do, along with pharmacy information sheets, and we've been looking at evaluating the impact of that systematic evaluation. We have a Provincial Dialysis Access Working Group so that we can try and convince the health authorities that creating peritoneal dialysis and vascular access in a timely fashion is actually worth the investment. And you'd be surprised how hard it is to convince people of that, no matter how much you show them the financials. We have the first ever, to our knowledge, provincial screening of all patients starting dialysis for tuberculosis using a new test called the IGRA. And we're in the final stages of actually developing all the transition algorithms for going to and from transplant from KCC, PD, and hemo, as well as corresponding patient guides, which is, as you know, a very big help because patients have a lot of difficulty often navigating the system. And so that's what this is for. You'll hear more about the Transplant First initiative. We have managed to get a new formulary for non-dialysis patients who have low GFRs to manage their symptoms. Prior to this, only dialysis patients who had chosen palliative or conservative care had access to some of these pain-relieving medications, but now if you've chosen not to go on dialysis, you also do. And under Dr. Boilou's leadership, there's an online KCC staff education series once a month, a Lunch and Learn. And so if you haven't gone to those, please feel free to look at them. Under Dr. Copeland's leadership, we've rolled out the Next Stage machine province-wide. That's involved staff and patient training and lots of protocols and resources. I think it really does take a village to actually get these sorts of things done, and I'm really glad to be a part of this village. We actually have a travel policy for Next Stage patients that keeps them safe and the machine safe. We've been updating the home hemodialysis tools to make sure that they support evidence-based practice, and we've been developing quality indicators and using our information system to make sure that that's supportive of the home therapy initiatives. So 30% of patients on PD need temporary hemodialysis in any given year. What percentage of those patients do you think end up staying permanently on hemodialysis? 30, 50, 70? Well, it's actually 90%. So we have work to do because there may be some things that we need to do differently to actually change that statistic. So good, glad you didn't know the answer to that. Next slide. So the Peritoneal Dialysis Committee, we just have a news announcement, actually, and we were interviewed for 11:30 radio yesterday about the PD Assist program. This is the first ever funded by the government provincial rollout of having an assistance program for patients in their homes to facilitate and keep them on peritoneal dialysis. We also have We got an Excellence in Quality Award in 2017 for this initiative, led ably by Dr. Singh and Sushila Saunders, and of course all of the other people involved on the Peritoneal Dialysis Committee. The sponsorship of PD nurses for a BCIT online course has been done, and of course we had this amazing Western Canada PD Days, and we're actually trialing some new peritoneal dialysis cyclers across the province, so we continue to innovate and we don't just sit and do what we've always done. The Hemodialysis Committee, we have an updated acuity scale, we've got a revised range of guidelines and patient teaching tools and an indicator report, and we've actually trying to manage all of the machines, et cetera, provincially so as to maintain some uniformity. So in last year, we sponsored a survey of nephrology across Canada and asked people how often they discussed expected survival with their patients on dialysis. And what do you think the answer was? Physicians, 10%, 19, 44, or 50? Well, it's 19%. So 20% of clinicians, physicians actually discuss expected survival with their patients. And again, when we're talking about patient-centered care, the patients are far less afraid about talking about what they know will happen to them than we are of talking to them, and maybe that's a lesson for us. So in that vein, the Palliative Care Committee has actually had 2 prognostication studies published in excellent journals, the Canadian Journal of Kidney Health and Disease and also a Palliative Care Journal. We've developed some quality indicators. We're supporting advanced care planning and ESAS across all the programs and enhancing the palliative care section on the website, including things that you need to know about MAID, medical assistance in dying. And what we've also done is we've collaborated with the UBC Palliative Care Fellowship Program and have sponsored the first ever Palliative Nephrology Fellowship. And Dr. Morgan Lamb is actually a nephrology trainee who graduated and is in that program. So that's fantastic. We have in our pharmacy and formulary committee a number of new community pharmacy contracts, again, trying to make sure that we actually have the pharmacies in the local areas knowledgeable about people with kidney disease so that anything that they're talking to the patients about is actually informed from a kidney lens, not just a general pharmacy lens. Well, you've already heard about the symptom management algorithms and the dialysis formulary that's actually more inclusive. Under Sean Barber's leadership, we have a GN committee that has a registry, a formulary that adjudicates medications and ensures access of the most current medications for people with these rarer forms of kidney disease, and a lot of province-wide rounds and education embedded in the kidney care clinic education things. And we're establishing a glomerulonephritis fellowship so that we can actually enhance the ability in the province to make sure that we really deliver state-of-the-art care in glomerulonephritis. I think Colleen already did this, but I think thank you is a pretty small word to say for all of the efforts of the Interior Health and the Northern Health group in terms of stepping up to the issues related to the fire. I was really proud that on all of the provincial emergency preparedness conversations, we could always say we have it covered. And that's because of all the work that you guys did, and it was really amazing to see the community come together with no fuss, no muss, no bother, and had to explain to people that paying for people to stay somewhere is not the wrong thing to do. But anyways. So other highlights, we've got some public outreach, World Kidney Day and Kidney Smart campaigns we do every year. I'll put a plug in. This year's World Kidney Day is also International Women's Day, and so we'll be celebrating women in nephrology, women caregivers, patients, as well as Kidney Day on that world. And we've got lots of social media events and other things planned. I'm going to run over time, but that's because there were these extra questions that I was told I had to put in, so I'll apologize. So I just think it's worthwhile to pause every year and say, where are we with our strategic priorities? So our theme 1 is infrastructure, so technology, facilities, and finance. So we were doing a multi-year application roadmap and upgrade to Promise. It too is 20-something years old, and it's getting a little bit ragged around the edges. We've got a lot of facilities and equipment planning that's proactive, and we continue to be fiscally responsible with our funding model and contracts. Our theme 2 is outstanding clinical care, and I think our patient-centered philosophy remains not just the patient-reported experience measures and the patient-reported outcome measures, but all of the things that you've heard David and Leanne talk about in terms of transitions in care, optimizing transplant first, home-based first if that's not an option, and making sure that we actually have the expensive new medications available to those that need them. We've also, under Anurag Singh's leadership, launched a telehealth Indigenous and Rural Communities initiative, focused a lot in the north, but also there are some other initiatives around the province, and so we aim to connect rural and remote and Indigenous communities in a much more systematic way than we have before. Enhancing our mandate in terms of addressing patient needs. There's the GN network. There's a polycystic kidney disease initiative that Dr. Mike Bevilacqua has been leading so that we actually are state-of-the-art in terms of measuring and access to therapies. And we're looking to synergies across other disease groups, infectious disease, cardiology, diabetes, to make sure that we really optimize everything. And then near and dear to my heart is research, knowledge, translation, and education, because what we're really trying to do is make sure that everything we do, we stop critically, look at it, is it working? And if it is, then we keep going. And if it's not, we don't do what we know doesn't work, and we don't just add on more stuff, we actually change it up. There are many, many educational opportunities for care teams, and we've also done all this education for primary care to help them, help us, help the patients. There are so many quality improvement initiatives across all the health authority programs. You're going to hear about some of them, so I won't go through them, but on your tables are the value add documents that actually describe in a little bit more detail what we're able to do with those value add dollars, and there are some posters that throughout that you can also see, as well as the postings on the website. So to conclude, the future is actually about sustainability and renewal, and I think the Renal Agency has invested in supporting a number of advanced trainee fellowships in collaboration with the University of British Columbia Division of Nephrology. So we have clinical fellowships that have been awarded to Judy, Melissa, Anushka, and Jun. And Judy's from Ireland, Melissa and Anushka from Australia, and Yun from New Zealand. So we're actually bringing people in and then letting them go home and tell the people how we do things here. We have a postdoctoral fellowship, as I mentioned, in palliative care, but also in hemodialysis that Elizabeth Lee is doing. And Mike Bevilacqua just completed and got the Robert Wood Johnson Award with the highest, best student and highest average graduation from the UBC Masters of Health Administration. So congratulations to Mike. Our core training fellows I've listed here. I list them here because some of them will do locums with you in your different health authorities. You'll hear their voices on the phone. They will transfer patients to and from you. So Peter, Chris, and Aaron are a second year, and Justin, Abdul, Priya, and Aiza are our first years. We also have 4 pediatric nephrology fellows, Sawan, Jean, Isaac, and Pratishi. And our new nephrologist graduated from the program is Mike Bevilacqua, and he's joined Fraser Health Authority. So there is a lot of new blood coming in, which I think is hugely exciting for all of us. I want a special welcome to our Hong Kong colleagues. So for the first time, we actually have an international collaboration and knowledge exchange. And today, Sydney Tang and Dr. Cheng are going to actually give talks in the 10:45 session, as well as Bonnie and Richard Yu being here as well. And this is started as a collaboration where I went to Hong Kong a couple of years ago and suggested that their meeting was very much like our meeting. It wouldn't be great to combine things. So Sydney agreed, and then Dr. Copeland and Singh went to Hong Kong last week and told the people in Hong Kong what we do, and now Sydney and Yukluk, Bonnie, and Richard are here to actually share our day with us. So thank you very much for coming. So lastly, let's just reflect on the last 20 years, because we've collectively built an amazing system of kidney care that I think many people come to learn about and is emulated. We've achieved together, and I think this is something that we don't talk about so much because it doesn't sometimes feel like it, that we've reduced dialysis growth. When we started in 1997, the annual growth on dialysis was 16% per year on base. We're now down to between 1% and 3%, depending on where you are. That's an impressive thing, and that was because we convinced people that kidney care before dialysis might just help to slow things and reduce things and help with all the things that I think it has helped with. We have a provincial lab strategy with calibrated creatinines and EGFR reporting that everybody said, oh, you're going to overcount, it's going to be a disaster. I don't think so. I don't think it was the wrong thing to do. And we have the network of kidney care clinics, which have some systematic way of managing patients. We have the highest independent dialysis rates in Canada and the most extensive financial support for our patients. They don't have to go elsewhere. Everything is paid for. And we actually have the only province-wide integrated information system, a registry. And while many of you may have frustrations with Promise, it's actually the only one that does what it does, and it's the only one from which we can get all this information. So the only way we have these slides and know what we're doing is because of that. So bear with us while we upgrade it. So it matters, and the reason we all do this is for our patients, and we have some small ways to celebrate our anniversary. We have some special chocolates, and we also have a trivia challenge, and I'll forget, Stephanie, the chocolates will come around, but the trivia challenge is on the app, but the chocolates, the dark ones are in the purple wrappers, and the other ones are in the not purple wrappers. So if you're not a dark chocolate fan, then don't eat the purple ones. I'll take them. Anyways, I want to just conclude and thank you all for your energy and commitment to everybody living with kidney disease. I am over, and I'm sorry, but I think this as a 20-year was perhaps a chance to really celebrate all of the things that have been done, the over 300 people that are actively involved in the committee work of the network, but mostly to all of you who actually really contribute directly to patient wellness. And I think I do remind you that the BC Renal Agency is us working together. There is no them. Okay, it's not the renal agency, we're the renal agency. So again, thank you very much for a great 20 years.